My first recommendation is that we have to do newborn screening.
Mm-hmm.
And so we have to use the devices that are the best fit your context.
Mm-hmm.
And if the context needs something really simple, user-friendly, you have the results at bedside directly. So it's easier to be sure that you can enter any patient affected by the disease into the patient journey care. Do it.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Olivera, and today we have the pleasure to have with us Professor Béatrice Gulbis. Professor Gulbis is part of the Department of the Center of Human Genetics from the Hôpital Universitaire de Bruxelles. She's also the co-coordinator of EuroBloodNet, the European reference network for rare hematological diseases. There she contributes with her expertise in genetic counseling and neonatal screening. Thank you for being with us today.
Thank you for having invited me to this podcast. Thank you very much.
So today we will be discussing her recent work on point-of-care tests for neonatal screening on sickle cell disease. And we will have first an overview of what sickle cell disease is, the type of mutations that lead to this. We will discuss the current testing technologies for sickle cell disease, and also what the future is and how can this be implemented. So my first question is, what is sickle cell disease? What mutations lead to this?
So, of course, it seems really easy to know that only one mutation in the beta-globin gene can conduct to the fact that there is sickling within the red blood cells. And the abnormal hemoglobin that is related to this mutation is the S hemoglobin. And when you are homozygous for it, you have the sickling, which is a polymerization of the hemoglobin within the red blood cell. But in fact, we have learned that it's much more complicated than this. There are many systems. So we know that other gene modifier can be encountered and that will work on the expression of the disease. One of them is related to the possibility to produce the fetal hemoglobin after birth. Otherwise, it decreases and it almost disappears. And we have learned a lot about the complexity of the expression of the fetal hemoglobin. And thanks to our researchers, it has been also applied for new therapies like gene therapies.
So why is it important to screen newborn babies for sickle cell disease?
First of all, I think that all of us, we would like to have a diagnosis, even if we don't have a treatment. So that's the first thing, maybe. But of course, in many countries, newborn screening has been implemented at a national level. And the first pilot was done in 1976 in New York on cord blood. And almost 10 years after, there was a randomized trial that demonstrated that prevention by oral penicillin gives a great benefit against infection, which is the first clinical complication that might conduct to death. So the randomized trial was stopped earlier because they saw this impressive benefit of the oral penicillin. And then 1 year later, the NIH declared that newborn screening had to be recommended because you need the diagnosis to apply the prevention. And of course, if you make the newborn screening, just keep in mind that you don't have just to do the diagnosis, you have to enter the patient into a patient care journey, a comprehensive care. Otherwise, you have only epidemiological data, but you don't prevent any complications.
What is the prevalence of sickle cell disease in Europe?
We know that in Europe, it's still a rare disease. When you have the definition of rare disease by the European Commission at the European level, we know it's less than one baby for 2,000 births. So it's really a few babies. But if you go to sub-Saharan Africa, the highest birth prevalence is in Nigeria. You have around 100,000 babies born every year. So that's a lot. So the figures are quite different from one region to another.
What is the normal test in Europe, and is it the same in these regions?
What has been implemented in the European countries where is the highest prevalence at birth, they implemented the sickle cell screening at birth within the national screening for inborn errors like phenylketonuria or hypothyroidism. And of course, in many European countries where the level of birth prevalence is really low, there is nothing done, or there is only screening of families who are at risk to having a baby affected by the disease. While if you look in sub-Saharan Africa, the picture is totally different. The coverage of the screening is only related to pilot studies still today, or the coverage is less than 50%. And the other great difference when you compare it to Europe, it has been demonstrated by the Newborn Screening Society that in 70% of the countries in sub-Saharan Africa, the only disease that is detected at birth is sickle cell disease, but not the other disease like phenylketonuria or hypothyroidism. And in my experience, what I saw often is the fact that pilots or coverage are related to big cities and not in the remote areas. So this means that you have to think about a way to be sure that you can reach those patients somewhere else. The other experience that I have, when we implemented newborn screening, sometimes you lose the baby. You have the diagnosis, but you can't catch the family and enter the child within a comprehensive health care. And this is really a problem. So we have to think about both things. How can we make the diagnosis and to have a 100% coverage? And at the other hand, how can we be sure that we can take care of those babies?
Mm-hmm. So now talking about this point of care testing technologies that you have been developing. Can you explain what they are and what is the purpose of this point of care testing?
We have been able to introduce innovation and related to miniaturization. So if you have immunoassays, what means immunoassays is the fact that you have an antigen, this is the hemoglobin S, for example, and you have an antibody, and then you can make a color with a band. So you can put it in a very small device. You don't need a power supply. It's really robust against humidity and high level of temperature and everything. So it's something really easy. It's also something that can be done, that can be performed by a nurse, by a physician, so someone without the background of a lab technician. And this is why you can think about to use it in remote areas. The cost is relatively low, but of course low, what does it mean? If your income is, let's say, $5 a month.
So you have been in the lab that has developed this test.
We have tested those devices.
Okay.
In the past, we were using isoelectric focusing. And then the evolution was with more sophisticated technique, if I can say. It's chromatography and also capillary electrophoresis. We compared all those point-of-care testing with those conventional techniques. So we compared one of the first point-of-care testing that was available on the market more than 10 years ago in my lab. And then, as I told you, our team worked a lot with our colleagues from Burkina Faso, from Mali, from Republic Democratic of Congo. And we have been working together to test those devices locally.
How successful are these devices in these countries? Have you been able to use them widely?
If you look at the healthcare system in sub-Saharan Africa, of course you have central lab and most often in big cities. But then you have different level and you go at the end in small centers where even the physician goes there once a week, for example. So you have to be sure that you can use a device over there without any training and you are confident with the results. So this means that for most of the patients, let's say if you have a normal result, so no hemoglobin S, you won't test anymore and you can tell the family or the patient that everything is okay.
So comparing then this point-of-care test to the conventional methods, how reliable are they?
For what we need, they are reliable, but I think that we have always to test it locally to be sure that we don't need a control. So the confidentiality that you have with the test is good, but you have to relate it to your population, let's say. So when you have a sickle cell disease, you might be homozygous for hemoglobin S. You might be compound heterozygous for hemoglobin S and C, and so on. The population that you test, maybe it's a child or an adult, so the level of hemoglobin S is very high. While when you are on newborn screening, the level of hemoglobin S might be very low. So you have to know the context, and with the context, you have really to test the feasibility and how you are confident with it. So this means, do you have false positive or false negative results?
So is there interference with fetal hemoglobin in newborn babies?
So it depends on the point-of-care testing that you use. So if you use the immunoassays, you don't look at the fetal hemoglobin, and there is no interference with it. If you have another test which is related to electrophoresis, you might have an interference with it. We call it smear. You might have a large band of fetal hemoglobin, and it can overlap the band of hemoglobin S. So sometimes it's a little bit tricky. But with this system, with electrophoresis, there is an added device that is related to artificial intelligence. So with this device, there is an interpretation. So you don't need that the nurse or any technician in the healthcare system interpret the test. It is done by the system, by the device. And it's a nice device because it's you can move it anywhere.
So it needs minimal training?
Yeah.
And you can implement it then in very simple settings, let's say.
Yes, indeed.
Is this the only device of this kind at the moment?
So there are many different techniques have been developed related to RNA, related to DNA, but many of those new techniques were not studied extensively. So they are still not available also on the market. I wanted to add something. A group in Sub-Saharan Africa, it's a Sickle in Africa consortium, and they just published a paper in this year, and it is really nicely explained the fact that when you want to implement point-of-care testing, you need the approval of the families. So they are working on newborn screening. So the families have to understand why we do this. Is it safe? And then you have to be sure that the individuals who will perform the test are also involved. They understand that it is for the benefit of the patients. Mm-hmm. Then you have to be confident with the test by itself. But there are also something very important, it's sustainability. Mm-hmm. So they involved also the politician. So they described this overall process, and we hope that we will have the results soon. Because again, if you really want to implement the newborn screening, but you can't do it for a long time, and you can't integrate the affected baby into the overall care, it's a loss of money. So you have to involve the stakeholders. So this paper is very nicely written in the way that we understand the overall aspects that you have to take into account to be sure that you will have positive results.
Are these tests also being developed for other conditions?
With those tests, you can look at the fact that you have no hemoglobin A and no other abnormal hemoglobin. So there is a clue that the baby is affected by beta thalassemia, but the newborn screening has not been implemented for beta thalassemia because there is no prevention that you can give.
Okay.
So it's not necessary.
It's not necessary
to have the diagnosis at birth. If you have to think about point-of-care testing, when I asked to my colleague, do you use it? Do you use it? It was never for newborn screening, but it was more when you have a genetic counseling, for example. If the father is there, often it's not so easy to have the sample. Mm-hmm. So you can test it during the medical visit. Okay. You can also test the whole family if they are there, mm-hmm. So the other children. Mm-hmm. So this is one of the use that I've heard about, even if there is no publication about it.
So what would be your recommendations for hematologists that are considering to implement the use of this point-of-care SCD testing technologies?
My first recommendation is that we have to do newborn screening. Mm-hmm. And so we have to use the devices that are the best fit your context. Mm-hmm. And if the context needs something really simple, user-friendly, you have the results at bedside directly. So it's easier to be sure that you can enter any patient affected by the disease into the patient journey care. Do it.
Mm-hmm. Mm-hmm. If you want our audience to remember one thing from this conversation, what would it be?
Oy. I want to thank you to highlight this, because I think that we have to collaborate all over the world and to be aware that what is our context might be not the context somewhere else.
Yes. Is there something else you would like to say that I have not asked and that is important to highlight?
Maybe when you think about point-of-care testing, I think that what is important to have in mind is the fact that you bypass several steps. This means that when you take the sample, you don't have to transport the sample. So you gain time. Then you have a test, and you have directly the patient or the family facing you, and you can show the results. If you see a band, you see something. It's like, you remember when we were during the COVID-19 periods, we test ourselves to know if we were contaminated, and could we invite our family or friends or whatever.
And do you have to take the blood?
It's a finger prick, or for the baby, it's a heel prick.
So it's as simple as a COVID test, you would say, but you have to take the blood?
Like for the overall newborn screening. So you can put the blood in a capillary or in a tube, or even on a paper. And then you put it in a buffer. You just mix it. You wait a few minutes. Then you put it on the device and you let it go by capillarity. And then the band appears. Or when it's electrophoresis, everything is in a microchip in a cartridge, and you wait for the migration of the band, and you look at the bands. So it's really easy, and then you can show it to your patients.
How long does it take?
Overall, 10 to 15 minutes. You know, when you think about point-of-care testing, it might be self-testing, like you said for COVID-19, but here it's someone who make the sampling and who do the tests. But you know, it has been developed also, for example, for CRP, which is a protein related to inflammation. And then the general practitioner can use it, just not to give antibiotics if it's not necessary. So it's also a test that you can do everywhere. So point-of-care testing has been developed almost everywhere. And in the intensive care, what they wanted to do is to put a device within a vein or an artery, so you can test everything. So this is also point-of-care testing.
So thank you very much, Professor Gulbis, for being with us today.
Thank you very much to you too. It was really a nice experience. And if anyone would like to have more information, of course, they are welcome.
To contact you.
Yeah, sure.
Thank you also to the audience for listening, and please stay tuned for more episodes.